And let's face it, we're all humans, right? Somehow medical education has a way to train that human side out of us little by little. And then at the end of that training, we come out and we're like, oh, these people are non-compliant. They don't want to get better. They're self-sabotaging, all these things that we label people with. And then we turn around and we forget what it's like to be human.
Welcome to Poppies and Propofol. I am so delighted to have my friend Dr. Zed Zha here to talk about her new book,
Yay!
Consented. Yay!
Thank you.
Well, Zed, happy Monday, happy Memorial Day. How are you?
Yes, you too. Good. How are you? I want to say something before we get started.
Oh,
You are becoming one of the most interesting doctors on Substack. I'm just saying that. I'm saying that because it's true. The conversations that you have with people, it's pretty all encompassing and it's interesting. I love that. I love it. There should be more like you.
that's very high praise.
I'm waiting for your book whenever that comes out.
I'm working on it. I will be reaching out to you for support as I work on a book. Well, Zed, for people who don't know you, you know, I found you on Substack and immediately was like, I need to know this woman. I think that was over a year ago. You were just working on your book. For those who don't know Zed, she's a brilliant family medicine doctor in rural Washington. And she just had this fabulous book that she put out called Consented, A Doctor's Call to End Medical Violence and Reclaim Patient Autonomy. So beautiful, beautiful cover.
Thank you.
And I remember one of the first things that you and I connected about on Substack was about trauma-informed care and how so many patients, we say that we care about patient autonomy, but then there's all of these myriad of ways that we find out that our patients we're not honoring their autonomy, and we're in fact actively trained in some ways to really diminish our patients' autonomy. And so I'm so pleased and excited that you turned that into a whole book, because you really bring both the deep exploration of that experience for patients and for your experience and your learning journey, but with such a beautiful humanistic approach. I feel like we know you better as a real person.
Yeah, thank you. One of the biggest things I think I've gained as a person, of course, as a physician too, but as a person mainly and a writer throughout this whole journey is how much I was asked to put myself out there, which I think is one of the only ways that we can do to level the play field, right? We work in such a field where there's this artificial but really real power dynamic and power gap between the doctor and the patient and the healthcare provider and the patient. One of the only ways we can bridge that gap and shorten that power differential is to volunteer ourselves as humans to start with. And let's face it, we're all humans, right? Somehow medical education has a way to train that human side out of us little by little. And then at the end of that training, we come out and we're like, oh, these people are non-compliant. They don't want to get better. They're self-sabotaging, all these things that we label people with. And then we turn around and we forget what it's like to be human. And all these things that we label people with are really just human acts, right? And then we ourselves are part of that act too. And so somewhere along the way, that humanistic aspect of being ourselves was lost. And that diminish that language, the common language that we have with patients. And so that's what I wanted to really write about in Consented. Of course, I want to point out the systemic oppressions, the inequities in healthcare, the things that we do to silence patients and to widen that differential. I want to write about that. I want to make it systemic. I want to make it organized. But really, I think you can do it as a doctor by being didactic about it. You can't give a lecture about it. You can't give a keynote speech about it. You have to write about yourself. You have to be honest about who we were before medicine, who we became while being in medicine and who we are today and who do we want to be in the future and how do we reconcile the human side of us and the doctor side of us.
That's incredible. And I'm I'm doing an interview right now. I love you so much. I mean, because I told you. Anyway, um, being a parent, it's awesome. I love it. And
I don't
um,
know how you do it. That's what I mean. You do so many things all at once.
um, one of the things that you were just touching on, and I remember when I was in medical school, I had been an ethicist before I went to medical school. So I mean, I had this idea that I was like, I should probably go get into a hospital and meet, some critically ill people to understand if this is really the profession that I belong in. Um, and so I had this whole perspective of having been in a hospital, but completely socially very interested and very connected with the patients, but not. I didn't know the words for all the ventilator settings. I had these like very cute notes that I had written down where I bought like a used medical dictionary and I would look up what is
Mhm.
assist control, which is like a ventilator setting from the ICU, and I was trying to like figure out through both the tutelage of my boss at the time, who was a former surgeon, and through being in the hospital, trying to figure out like what is happening here and what are the relationships that are happening that we're seeing. And so being able to be at that nexus of being in a position where I didn't have a lot of power, but I was able to observe the power dynamics
Mm,
much more in this very intimate way.
mm,
And I learned so much. And then when I got to medical school, it was both valued and devalued. Like, oh, you care about
mhm,
people too much. You are
mhm,
too invested in the patient. And I was like,
mm.
how is it possible to be too invested in the patient? But these
Yeah.
are the things that these people who've already been indoctrinated into this
Yes.
messaging then perpetuate it. And as a educator now, there's so many times where people are like, "Well, why doesn't this XYZ fill it in? Why doesn't this get taught in medical school?" Because everyone
Mhm.
seems to think that medical school is where the vast majority of the both learning and teaching is taking place. But of course, as you and I both know from, residency training, and there's so many people who've already finished medical school who are providing this both explicit and implicit education that tells us what kind of human are you allowed to be as a
Yes.
physician.
Yeah, there is this really interesting unlearning process almost. I mean, if you remember, this is like, of course, a long time ago, but when we applied for medical school, right? When we were like the starry eyed young people who are trying to get into medical school, we were like these pretty wholesome people to start with. I mean, we were like, of course, we had a lot of privileges, right? Like I mean, today, to this day, medical school isn't as inclusive as we want it to be. It's never been that way. Of course, it was never designed that way, and today it still isn't. But in many ways, we were asked to be a good student, of course, as a fast learner. We were also asked to write these like killer essays about what humanistic approaches we want to adapt when we become doctors, and what kind of doctor, how humanistic we want to be, what a kind like healer we would like to become. We have to do the research, and remember, we had to do all these like community volunteer like hours. We have to prove ourselves to be like caring, and not just about individuals, but also about communities, group, and inequalities and all this stuff. And so we come in thinking we were like, these people are going to like change the world and become healers and massively compassionate. And then we get trained little by little in a way that's so rigid and systemic. And then we get told along the way, oh, you care too much. You need to remove yourself from blah, blah, blah. And then you need to, and then we get fed these words, right? Like I distinctively remember the first time someone used the words, oh, they're non-compliant, or like, oh, this patient is difficult, or um, the first time someone sent me the line that literally said, you should ask them where did they go to medical school. Like these are episodes of your life where you're like, I feel split right now. I was not like this. I was a real human. I was a compassionate individual before I came to medicine, and now I'm being invited to join the the other side, almost the dark forces. And who do I choose to be right in this moment are so many moments like that I wrote about in Consented in my book, because those are distinctive moments where you have to make a choice. Do I conform to be the rest of the doctors I admire to be? Because, a lot of things are on the line. You're like already $200,000 in debt. You're like, half of your life you've done toward this thing. And also this particular rotation where you're going to get this particular grade from this particular person will very likely determine who you get to become in the future. If you fail this rotation, it's like you let this ball drop and everything is going to crumble. So much is on the line. Which part of myself do I lose? And how do I hold on to that? And how do I find my way back to myself years down the road? In fact, the moment I thought about one of the, people ask me, why did you write about medical, what I'll call medical rape culture in my book, which I'm just going to quickly define what medical rape culture is. It's the healthcare environment that normalizes or trivializes the violation of patients' bodily autonomy while claiming to provide care. That's what I'm talking about. That's the harmful medical culture I'm talking about. So how did I realize I'm in this culture and I contribute to this culture was one of those distinctive moments in my early educational journey. Whereas as a third year medical student, short coat, remember our short coats, that, the short coat
For
signals that you have no power.
for folks who are just learning about the short coat, in medical school, many medical schools have a tradition where uh, medical students wear a literal coat, the white coat that is short compared to once you become a resident, you get to have a full length coat that fully covers your bottom.
Behind.
Um, yeah, so wearing a short coat is a visual indicator to everyone in the hospital that you are a student and not somebody who has a medical degree. Although I will tell you, when I worked as a medical ethicist, before I went to medical school, I was horrified. They gave me a long white coat
Mm.
the first day. I was 21 years old.
Oh.
I had just finished my bioethics degree. And I was like, I really, are you sure you want me to wear this? Because I am deeply concerned. Because I knew that there was I was like, this is for doctors. And like, I just finished college. But anyway, yeah, the short coat,
It signals power, and the short coat signals the lack thereof. Like, you are to be
absolutely.
seen. You must be the first person who is seen on the ward. Like, if the resident rounds at 6, you're rounding at 5:30. If the residents round at 5:30, then you round at 4:30. That's
You
the
get
that's
the
the right. You
first
get to,
opportunity to torture the patient.
but you're not to be heard from. You are to be seen first, and so that we know you're there. But when the healthcare discussion, like the decision discussion happens, you're not to be heard from. So that's where I was as a third year medical student, first medical rotation, first, second year, mostly, it depends on which medical school you go to, but largely you're in the lecture halls. So third year, you go to your first rotation. And my first rotation ever was OBGYN. Of course, love OBGYN doctors. Today, many of them are in the front line fighting for patient bodily autonomy. So but OBGYN as a specialty has a long history of unfortunately violating people's bodily autonomy. And so this was, my first rotation, wearing a short white coat, first patient that I've seen, one of the first patients I've seen, a young woman, much, a few years younger than me. And I was young too, by herself, was 39 weeks pregnant, almost due. And first time I met her, she was half naked, which is weird. It's a weird way to meet people when you walk into a room and they're half naked. Their private part is just covered by this thin paper drape, right? First time I met her, and she had no idea why she was half naked. She was offered to do a cervical check to check how dilated her cervix was. She was a healthy first time mom. There was no medical indication to check her cervix. Today, that is not my practice. If there's no medical indication, I stay out of people's businesses. That was not the practice back in this case. So I walked in, and then I watched my attending do a very painful cervical exam in a way that was so violating. And I was a feminist, young, starry-eyed medical student, set out to make a difference. And I watched this, and I was not to be heard from. I was not to say anything. And I related to this patient a lot more than I related to my attending doctor, who was an older man, right? And so I remember the patient both with verbally and non-verbally said no multiple times. Like she said no, and she said stop, and then she closed her legs. I mean, these are all ways to withdraw consent. I mean, arguably, she was not informed about what was about to happen, so there was no real authentic patient consent, period. And then she explicitly and implicitly withdrew her consent in multiple ways. What did my attending do? He pushed the patient's leg down with the arm, keeping it open instead of stopping and withdrawing his hands and saying, reassessing, what can we do to make this more comfortable? Is this really necessary? What can we do? He said, he said, relax, like as if you could just relax. It's almost like, yeah, just like take a chill pill, and then, and he said, almost done, as if the person in front of us is no longer a person, who lives in a body that's going to remember an experience for its lifetime, but a task at hand. That's all she had become at that moment. And that was an invitation, explicit invitation in my career to see the patient from medical gaze. That's the medical gaze that we're talking about, right? From this weird angle of the patients, despite the fact that we never met before. Then when we came out of the room, the attending kind of threw the gloves into the trash and was like, oh, like, if she had put her legs together 9 months ago, it wouldn't be here today, would we? And that was to me, that comment was made to me, but it was an explicit invitation for me to join on the joke about how the kind of comments we can make, we're allowed to make about this patient. And so
And
the
and
choice
and
is, yeah,
and you're in this position as a trainee, whether it's as a
yes,
medical student, as a resident, as a fellow, where the survival skill is to stay quiet. The survival skill, as you mentioned, you have to finish. If you challenge the people with authority, I mean, I did not do well on many of my rotations, and it was not because I didn't know my
medical.
physiology. And I was trying to keep myself together, and like I had a very similar experience to what you're describing. It's actually part of
Mm,
why I just felt like I could not become an OBGYN despite really thinking that that was something I would like to do. And that is this terrible choice because not only is it an invitation to participate, if you decline the
mm,
invitation, you may also be punished. So there's
correct.
no correct answer.
No, and
I mean,
added to
there are
that,
there's an ethical answer, but it doesn't
there's
mean that you're
yes,
gonna
you're right.
you're not gonna finish. You may not do
Yeah.
well in your rotation or get a job.
If I was allowed to make the ethical decision at that point, I don't think that the book consented would even meet the world. There's no necessity for that anymore. But I was,
I
for
wish.
I was a young woman. I related to the person in front of me, the patient whose bodily autonomy was disrespected more than I related to my attending, but I was on my way to become that. And I thought, and also added to that, I was a new immigrant. I was maybe 6 years into my immigration journey into the United States. So there was a cultural barrier, language barrier. There was this hierarchical, like, power barrier, all the barriers, right? So I didn't say anything. I might have even agreed that that was funny. What he made comment was funny. I wrote that in my book. And I remember thinking, okay, I'm going to get through this. I'm going to shut down. I'm going to get through this. And I had this like out of body kind of like experience where I felt like I wasn't looking at him, his technique, observing his techniques anymore. I wasn't absorbing knowledge anymore. I was just trying to survive the experience. And then I thought to myself, I'm never going to become like this. When I'm attending, I'm going to be so much better. That's my thought until years later, I did become that. And I wrote about that moment in my book where I realized it's almost like we have this invisible monster in our nightmare that we are all in with the patient, and we couldn't name the monster. We couldn't wake up from it. You're floating around and you can't do anything. And you can't name the monster until one day I realized I was that exact monster.
Yeah.
Years later, I was a country doctor. I thought I was doing really great. Young attending, had lots of clinical responsibilities. Um, and then that's the capitalistic part of medicine, right? That if you do well, they're gonna reward you by giving you more work to do, right? So I was seeing like, this is during the pandemic as well, and I was seeing like 35, 40 patients a day. I had a patient in labor in the hospital. I was on call. I was precepting students, and I had supervising physician assistants and all these responsibilities. So everything was looming over you. Your anxiety level was like high this whole time. And I was doing a pap smear for a 21-year-old patient who, it was her, obviously her first pap smear. And she was clearly very nervous. And the moment when I walked in and I saw her body language being so rigid, so nervous, my first thought wasn't, I gotta do a good job, like, like making sure she's authentically consented. That was not my first thought. My first thought was, oh God, this is gonna be a long visit, isn't it? And my first thought was, what about my to-do list, my in basket? What about these things? So like this task is gonna take me forever, you know? And so I did this pap smear, and I realized in the middle of the pap smear, of course, the patient was pretty, tensed up. And then instead of saying the things I was supposed to say, like I think the thing, instead of slowing down and withdrawing the speculum, I said the same thing as my attending did years ago. I said, relax, as if, right? I said, relax. And then as soon as she relaxed, I pushed the speculum further. And then, of course, she tensed up. So that whole experience happened, and I was like, oh, I can't believe this patient was so much drama, right? So I walk out of the room, and it's almost like in my mind, it's the same scenario. Like I'm throwing away the gloves up. I probably wasn't, whatever it was. Kind of, I'm equating my own experience to my attending's experience. And I made a comment, I think maybe to my medical assistant, maybe to myself, and I said, oh, she acted like I raped her or something. And that's when I realized, you know what? It's like rape. That's exactly what this was. This was a violation of bodily autonomy. We were talking right before we came on live. The definite legal definition of rape is that there is a body orifice that was entered by a body by a body part, or by a penetrating object without consent. That is the definition of rape, right? So isn't that what we do sometimes? We insert the speculum, which is a penetrating object, into people's orifices, right? And then sometimes we do a terrible job with consent, like obtaining authentic patient consent, where people are allowed to withdraw consent for whatever reason at any time, no question asked. We're terrible at doing that. Doesn't that fit that definition? So that's when I realized this is rape culture. I mean, of course, like, no one set out to be a criminal, right? Like, that's not what I'm saying. This is vastly different than the criminal act of rape, right? This is not we're not talking about a crime. We're talking about a insidious, widespread culture that prioritizes our to-do list, over patients' bodily autonomy. We're talking about a culture where we, in the name of healing, harms people sometimes more than we help them.
Yeah, and the other thing that I think of when you tell that story is that we have I don't I can only speak for myself, but there are so few examples that I had to witness things being done well. I mean, as an ethicist had ideas about what you think should happen or what you think would be better, but it is challenging when, you describe your experience of witnessing this behavior, being disturbed by this behavior as a trainee, and you I'm sure saw variations on that same behavior in many different iterations throughout your training. And it isn't until you are an attending and suddenly you've had this years of indoctrination,
Hmm.
and you maybe have still never seen somebody really do this well. Or if you have,
You're
it's
right.
been the minority of experiences. And so, and
You're
I
right.
too have found myself as a junior attending being like, wait a minute, I don't have to behave this way. I don't want to behave this way. I have never wanted to behave this way. And the only
Hmm.
person now making me do it is me.
Yeah. That and the oppressive, medical educational culture that's passed down at us for hundreds of
Sure.
years, right? That's
Right, but you
authored by
realize
somebody else.
but you had that realization, and whether it was because of the sort of the poetry of being in an almost identical situation and realizing that it had become part of you despite
Mhm.
having this deep commitment as a younger person to not do that. And I think it's challenging to then realize like, "Oh my gosh, they did it to me too." Because I think that when
Mhm.
I started, I
Yes.
somehow thought, "But I know better. I know better. I know that there's these problems in our system. I recognize that there's things that are being said and done that I believe are wrong, even if I'm not allowed to voice my opinion, or I can't take those risks because of the debt, or all these other things that come up, that convince us to stay silent." And I think when you get to the point where you're like, "No, they got me."
They
Like
got me.
I thought I would be able to like prevent this, but the indoctrination is can be so complete.
Yes, and it's trauma is secondary trauma, right? That's we like as a person who identified with my patient, first time I witnessed it, I was traumatized too, just didn't realize it. So this writing a book about the culture that I come to stand against today is that part of that healing process for me as a person, which is why it's so easy for me to put myself out there. I think my editor and my agent would tell me that in this book I implicate myself. I implicate myself and I share my vulnerability to the maximum with people who read it. And I still do today. I think it's one of the scariest things I've had to do. And I worry about what I'm viewed as by readers and by people within the system. I also feel like it just has to be that if you're going to write a book that someone's going to pick up and read through and through, that's the only way to do it. You just have to tell the truth, the radical truth. And sometimes I think about that too, like this way that we were taught to behave, right? This narrative that we were fed. I find myself resorting to that very often because we're so burnt out. We are so burnt out. I am so burnt out. Everybody's so burnt out in the system. When you're so burnt out, what do you like when you're like just robotically going through your day? What do you resort to? You resort to the way that you were taught for like that. It wasn't just you, you weren't taught to, you were punished into, this is hammered into you. So whenever I hear myself say things that resemble the medical rape culture that I was taught to embody, that's when I know I'm too burnt out to be a good doctor in this moment. That's when I tell myself, you know what, this they've got me again. They got me before, they're getting to me right now. What do I do to stand against that? Like how can I bring my own person? This is when I'm like, take a breather and what I need to find my human side. Is this where we tell a joke with patients? Do I ask about their cat right now? Like, should I be asking them for advice about like how to get along with my dad? Like, what can I do to bring our human side into this conversation right in this moment so I can be also rescued out of my old way of thinking? I do dive into the how the society has transitioned from no means no to yes means yes to authentic consent to enthusiastic consent to that transition. And I think that we are lagging behind. Medicine, as a major branch of society, we're lagging behind in how we catch up into the rest of the world. The world is moving on to consent culture. Well, we hope that is moving on to consent culture, and medicine hasn't even started. Like we don't even take people's no for no. Like no means no was so 19 whatever, like 1970s, 60s, whatever, right? Like that was the first step. We're not even there yet. We didn't even start in this journey yet. But in my opinion, I think that I think we should be talking about like authentic consent or authentic patient consent, which is the authentic medical consent is an ongoing process of trust building through conversations, transparency, and respect for bodily autonomy. No questions asked. Like there, it's not a negotiation. It's not a signature. It's not a legal document that covers nothing but our own asses. This is
And
it's
doesn't even
on.
and the
It
signature
doesn't
doesn't
even
even do
cover.
that. I mean,
You know, you should know. Yeah.
this is what I teach all of our medical students when we talk about consent. And this whole idea, even this word that you use, which is very tongue in cheek for folks who don't know, this word consented, like this is the language that, if you get sent to do a consent form for a patient, your senior resident or your attending will be like, did you consent the patient? Like, oh yes, I consented them. And it really just
Yeah.
means that you got the signature, like that was
That's
the
all you did.
task.
Yeah, right. And then this example that you just gave itself is problematic, right? Because like when we as if the surgeon, if the surgeon who's performing or the person who performs the procedure isn't the one who had a open ongoing conversation with the patient who's about to undergo the procedure, is that real consent? Like when you send your medical student, your resident to do the consent, sure, like it's great that they are informational, but they're not you. They're not the one whose hands you're going to be like operated under, right? So I think that in itself is a perfect example of the hierarchical power dynamic that we get embodied into in medicine, and
Bec-
we
Yeah.
forget this is absurd.
I'll tell you, as an intern, I got in so much trouble. They made me do a neurosurgery rotation, which there are some lovely neurosurgeons in this world. They are not the people, those are not the people I was working with in my rotation. And one of the things that they they wanted me to do is they were like, go to the pre-op clinic and like do the consent form for the patient. And to their credit, this is a patient who supposedly had met with the attending surgeon in the clinic and had had the conversation. And like I was just supposed to take care of the documentation the day before. But I get to see the patient, and the patient has a lot of questions. And do you know what? I am not a brain surgeon. I was an intern, an anesthesiology intern, and I was like, "Oh man, I'm going to need to get you a real doctor." And
You're like many things, but a brain surgeon is not
not
one of them.
not the person who should be giving you. I do not have the expertise that you need in this conversation. And so I went to the senior neurosurgery resident who was available and said,
Mm.
I need you to come talk. I need you to come talk to this woman. Like she has a lot of questions and I can't answer them. And he was like, your job was to get the form signed. And I was like,
Oh yeah,
that is,
perfect example.
and I had no fucks left to give in this rotation by this point, and I was just like, "That's completely unethical. I am absolutely not doing that, and I will be happy to get her signature when y'all go answer her questions." And, it's just they did
So
not like
that's
me.
a
They
that's
did
a
not like
story how you didn't become a neurosurgeon.
There's
Um, so yeah, so I think so, and that also speaks to the hierarchy, right? Like you as you're a resident, right? And you went to
Mhm.
find the senior resident, and then if the senior resident had to do something, they're gonna go find the fellow, and the fellow's gonna find the attending, and then so like we have to like in order to do something, you have to bother so many people. Each layer of people that you bother is gonna give you more crap about having bothered the person before them in the first place, right? So all of that. So what do? You what I don't know what you do. Like, can we say what we do? I don't know what. So the thing I wrote about another thing interesting concept in our in my book Consented, in the chapter on pathologizing gender and sexual diversity, right? Or standing with gender and sexual diversity. There's this idea of like insurance imposed steps, right? Of course, like in the example of gender affirming surgery, many insurance companies, they require this form to be provided by the psychologist to evaluate the patient, to make sure that
Mhm.
this readiness letter, right? So in the readiness letter that I wrote about in the chapter, uh, there's explicit wording that says the patient understands the risk and the benefits and the alternatives of the surgery to be like that they are going to undergo. So
Which, of course, a
I
psychologist
love
cannot assess.
psychologists. I know, like in all due respect, like with love and respect, you don't know, you can't do that. No one can. The only person who can do it is the person who is going to perform the surgery. And so that's a good example of how we treat consent today. We say, was the patient consented? That's the wrong question to ask. The real question is, did we are we having an ongoing trust-based conversation
Mhm.
where patients are allowed to ask questions, to allowed to withdraw consent, to change their mind for any reason at any
Mhm.
time, and we don't negotiate with them at
And
all?
that they can withdraw that consent, and we're not gonna, like, judge them and be assholes.
Yeah. Oh, yeah. Or like, oh, these things that we say, like, oh, well, that's because they don't want to get better. Like, and then, or like, they're self sabotaging. And these are the words that, right? So I was, I writing this week's newsletter, and I want to write about the lying patient, right? And I remember, reading the research, and I wrote about that in the chapter 3, I think, called patient blaming and gaslighting and medical gaslighting. And so in the chapter I write about how many labels that we throw around in our in the charts, and we label people. And one of the things is non-compliant, like medication non-compliance or whatever.
I hate the word
And then, yeah,
non-compliance. It,
no,
like,
I know,
makes me
I
feel
know.
itchy.
Yeah, whenever new trainees come to me, they're like, the patient is non-compliant. I say, you know what? We don't use that word. Whatever you do outside this rotation, I don't care. But in this rotation with me, we don't use that word anymore. Like, we don't do it anyway. So, the things that, so if you read the literature, read the research, there's so many ways, reasons that people don't take the medication as directed. They're
Mhm.
medical noncompliance. Many, many reasons, including where they're confused about the instructions are confusing. They're conflicting information from different specialists because we compartmentalize everything. And there is, they don't tolerate them. They're too scared. They haven't been given enough information. They couldn't afford it. Their medication gets stolen. Things happen. Life happens, right? But you know what you don't see in the research, in the reason for not taking the medicine, you don't see, I just don't want to get better. Like,
Yeah,
that's just
nobody
not
said
one of the reasons. Nobody does
nobody
that. Like, come on. Like,
nobody
I
goes.
want to, sabotage myself. I just want to I want to keep getting sick. And because I just love the doctor so much. I want to pay to go to their office just to hang out. Like, no one, I mean, no one does that.
It's well, and it's interesting when I have that conversation around compliance, and I do a lot of work around solid organ transplant, and so adherence is something that's really important. Like, are you able to take these medications before transplant so that we know that you'll take the medications after the transplant so that the organ is not rejected? And yet, it is really challenging to have those sorts of conversations with clinicians who have this focus on noncompliance. And
Mm-hmm.
I often find as trying to bring that ethics perspective to be like, okay, but but why? Why?
Mm-hmm.
What did we do to help assess why that happened?
Mm-hmm.
Because I'm hearing that there's a lot of ideas, but
Mm-hmm.
there's not a lot of evidence. And I just love
Correct.
evidence. I love for us to just
You
find
love it.
out
Yeah.
the
Wouldn't it be
patient's
nice if
perspective.
everybody just loves evidence? You know what? You know what? The most important piece of evidence is, of course, like, we base everything we do on data. That's great. But the
No,
most
but like the
important piece of
patient.
evidence is the patient. Yes.
Yeah.
The person, how the patient is doing, how are they able to do something? That's clinical fact. That
Yeah.
is medical evidence, right? Like, so I was just did this newsletter I'm gonna send out tomorrow. I'm gonna write about this patient who was so afraid to tell me the truth, and then I was like, "What's going on? I feel like there's something going on."
Mm,
Until they told me, "Well, I haven't been truthful because." I was worried that you were going to judge me, but really, I
right.
have not been taking my injection every 2 weeks as you prescribed. I've been taking it every 4 weeks, and then I was like, "So, are you better?" And I mean, he was totally better. He used to be covered in rash, and now he's like a normal person. So what? Like, I prescribe it every 2 weeks, and you take it every 4 weeks. Is it working? It's working perfectly for you. So that's the most important piece of clinical evidence that the medicine is working. Because like Q2 week, every 2 week injection or medication schedule, that's a gold standard of care. But where does the standard come from? The standard comes from statistical average. It's an average, right? That's how mathematics work. There are people who do better with more, people who do better with less. And then on average, every 2 weeks is how people usually do, right? So by definition, you could be either like small, like less or more. That doesn't mean you are defiant. that just means you deviate from the average, which is a mathematical calculation. And so isn't the most important piece of evidence the clinical like the clinical scenario of the patient sitting right in front of us, which is why my newsletter, shameless self plug, is called Ask the Patient, because that's the expert who's like sitting right in front of us of this whole entire topic of somebody's health. The expert is right in front of us.
Yeah, that's actually one of the things I may have told you this before when I teach our medical students, and we talk about consent, we talk about adherence, we talk about all these other things, and I'm always asking them, okay, so what are you going to do? What are you going to do? And we're it's all this setup to get them to consistently say they're going to ask the patient, and then I have the whole room cheer that everyone knows that they are going to ask the patient.
Yay.
Um, I mean, and it sounds silly, but it's just that, like,
It's
that's
so
that's
silly.
the answer the vast majority of the time is it's like the patient is the answer to understand the patient, to deeply respect the patient. And you gave a lovely list earlier of sort of the behaviors that clinicians need to have. And I oftentimes remind people, like, if you want people to trust you, that's not actually something that you deserve. That is something that
Hmm.
you earn
Correct.
by your own
Correct.
trustworthiness. Like,
Yes, and maintain.
you have to
You
behave in
have
a
to behave.
trustworthy way for anyone to trust you.
Yeah, hello. I mean, that's something that is so normal. That's like a common sense, right? Inside medicine, when you encounter someone and then they behave in a certain way, and then sometimes I step out of the framework of I'm in the medical profession, and I think this person is so not cool in medicine. Like this attending or this resident or whatever is so not cool. I wouldn't even hang out with them outside of work. Like if I met them at a party and they talk about patient or about someone else or about me this way, I wouldn't even sit next to them. But in medicine, because they're my higher up, they are in the hierarchy that's above me. I just have to sit here and listen and like take what they say as the standard. That's just totally absurd. It's absurd.
We have a visitor.
Hi.
We have another co-host.
I love the cape. Was that a cape?
Yes, yes, she has a little this is my dog Sierra. She's got a series of tiny little capes
Oh yes, I
or
think somehow
kerchiefs.
that
I don't know. She's
whatever it
very
is.
cute.
Cute.
Um, yeah, it's I I continue to try to work on my communication, and in particular, one of the things that you were just mentioning is, how when you engage with a clinician who is saying things that are disrespectful or that at least I it certainly sounds like that. And I have really tried to practice the art of, asking a curious question about what they mean by that. And if after the answer to that curious question, it turns out they are really being disrespectful, I've, now I'm in this position of authority, right? Like I'm a senior ethicist, I'm a senior faculty member, and it has taken a lot of years for me to learn how to do that. And we've talked a lot about sort of, the hidden culture in medicine and the ways that medicine sort of dehumanizes us and then we dehumanize other people. And I would love to help be a bridge whenever it's possible to bring that person back into their own humanity. And that is an act of it is an act of love. I but and it can be sometimes it's a total fail, but occasionally it feels um like it was a worthy act to try to reconnect with what does it mean to respect a patient.
It's
So I'm
like,
the asshole and I have to like call myself out too.
and we have to apologize, and that's totally okay. Like, we're just normal people. Sometimes I've been fired by patients before. Fired, right? Like because sometimes it's because we just wasn't a good match, or sometimes it's because I behaved in a way that I would have fired myself too. Hello, and then but I think like one of the things I want people who are listening to know that we are so deeply human, but our human side has been so deeply hidden and kicked away and punished throughout our career that sometimes it's really hard to reconnect with that. But there's so many of us, like you, like me, trying to undo that first within ourselves, but also push that onto that movement onto the rest of of medical culture. That I think what like the things that happens today is not definitive. It's like so many times my interaction with patients at the moment I couldn't have been taught. You couldn't have been a humanizing attending to humanize me. This wasn't going to happen. I just wasn't there yet. I was not ready. But I think back today, those moments that I was invited to be human again by someone who was more advanced in their own introspective, like self-examination. I think back at them and now I accept that invitation. And now I wish I could have accepted it back then, but I also need to give myself grace. You need to give yourself grace, right? We did the best we could. We did the best that we could to survive. And we're here today. That's how we get to have a voice and make a difference. But in the moment, I just wasn't ready. However, it makes a difference today. I think back at them and I accept that invitation. I want to extend that invitation to everyone I train or everyone I encounter. And so I'm hoping that by putting myself out there through this book in the personal stories I write about, people will see me and by extension, people in medicine as fellow humans. And then we can somehow find common ground and find our ways back to each other like people.
Yeah, that's
And like
beautiful.
how your your dog looks at you like so there's
I
so
know
much love and admiration.
she's so sweet. Yeah, this is why I told my husband as long as I'm practicing medicine, I need a dog.
Yes. Yeah, you need to take care of yourself. You need vacations and you need a dog.
Yeah. When you were I've been thinking a lot about this too, where you and I have both talked a lot about the vulnerability required when you have made a mistake. And it's so interesting that, medicine continues to try to say, oh, we want to do quality improvement. We want to address medical errors. We want to prevent medical errors. We want to respond to medical errors. We want to learn to apologize. Um, but there's still such an underlying vibe in medicine that you have to be right all the time. And it is
Hmm.
in, of course, direct conflict with all of these other far more important goals.
Yeah.
And it's I mean, I think you and I have ourselves both been on this journey to be like, okay, well, nobody's showing us how to do this, so we have to sort of figure it out on our own, and then try to share that with others. And I think it never gets easier. It's always
Hmm.
hard to admit that you did not show up the way you wanted to, that you did not show up as the kind of human being to another human being that you wanted to.
Hmm.
But I've not once thought that it wasn't worth it to do that. There's
Uh,
a comment in the chat that I thought I would read. I always found it disrespectful, aloof, and avoidant when docs talk about patients, quote, malingering in their office.
oh gosh,
It
yeah, I saw
seems
that
like
too.
the it seems like the doc is avoiding fixing the problem and just blaming it on a red herring instead.
That's a parallel that I think it draws such a distinctive, like clear parallel of medical rape culture and the
Mhm.
societal rape culture when we talk about rape culture, right?
Mhm.
Malingering is the ultimate patient blaming, it's the victim blaming, right?
Mhm.
It's saying it's as if to say, well, they're crying rape or they or that like what did they do to deserve this outcome, right? So in
I
my
think it's
opinion, are yeah, go ahead.
Well, I was going to say I think it's also the flip side of what we've been talking about in terms of being able to admit that you don't know. And
Right,
so often I feel that there's what it's both of those things
right.
happening at once, right? Like it's a clinician being able to say, like, well, I don't know what causes this thing, so therefore you must have made it up.
It's this dichotomy of like either you fit into my textbook or you don't exist or this doesn't exist,
Yeah.
right? Like, and then we forget well, like COVID has basically taught us the fact that like the textbook is never going to be done being written, of course, right? But also like who wrote the textbooks? Like I'm sure you've written texts. The people who wrote the textbooks are the you know the like the people who wrote medicine. in history, throughout history, are the people who are like the healthy, able-bodied, cisgender, straight white men who weigh 70 kilogram exactly, who like could be astronaut but chose to be in medicine instead, right? Does that look like you and I? Like we didn't write the textbooks, so what makes us blindly inherit that? Like that's not our inheritance. We it's not until people who look like our patients and look like us get to define the symptoms and direct the care, that's when equality or equity has really truly being achieved in medicine. Just us having more people of color, people just having more women enter medicine isn't going to be the answer. We have to also examine what's being done and what can we do to do better, and then actually write the textbooks to do it.
Well, I mean, and you and I have also, talked. We're both women, and we've both been the problem, and so it's also something where it's not that there's any inherent, you know, good or bad gender or anything like that. It's a matter of what are the behaviors that we have been taught and the values that we have been instructed to uphold,
Hmm.
and doing the collective labor of saying, okay, we need to re-examine how did we get here and who do we really want to be. And I think especially now, um, we have such a crisis of trust in medicine that
Oh
is,
yes.
deeply deserved on in many ways. And again, how is it that we become trustworthy? And it's not there's not some like magical easy answer to that, because it really is, such a massive cultural shift that we need to undergo. And it's hard.
Mhm.
It's
It's
hard,
hard.
and it's hard when, early in this conversation, you were talking about how, there's easily times when we can be very flippant about our frustrations. And
Hmm.
oftentimes, that is just not something that makes makes a positive difference in a relationship.
No, sometimes we could be dictators. And sometimes and that the power that we uphold every day in every single patient interaction is unavoidable, like it's without a question there, palpable all the time. And if
Mhm.
we don't do something to invite that the evening of the field, like of that power differential, if we don't do something to reduce that power differential, it would be really hard for patients to take that initiative. And sometimes like at the end of like sometimes conversations, and people ask me to give advice to patients and what can they do to advocate for themselves, which I think is a valid question, right? Like, of course,
Mhm.
but I am not an expert in patient self advocacy. In fact, what I'm saying is patients have always advocated for themselves. Like, who doesn't advocate for themselves? I don't know. Like, what a privilege would it be for someone to not have to advocate for themselves, right? Like, I'm a physician. I'm a intelligent like woman who speaks medicine. Like, even I have to advocate for myself in my own care. So who doesn't, right? And so it's not the question isn't what can patients do better to advocate for themselves. They've done it. They have been doing it. It's time that we do the same.
Absolutely. It is frustrating for patients to feel that it's their responsibility to overcome the power dynamic that we bring.
Mm-hmm. Yeah.
Um, what are things that you do? Are you I'm imagining there's some of the things that I do when meet patients before they get anesthesia,
Mm-hmm.
um, to sort of to try to reduce that power dynamic. I can't make it go away, but I try to do what I can. What are what are techniques? What are things that you do when you meet a new patient or you're seeing a patient that you might recommend to other healthcare providers?
Well, I think I'm hilarious. I think I'm
I
funny.
I agree.
So one of the things I always remember something from our last interaction, and I bring it up. So last time someone was like they were dressed in camouflage and they were like about to go hunting, and then like next time I see them, I was like, oh my gosh, did you catch something? Like ask questions like, "Oh, what do you do? This is like, is this the term that you use when you go hunting and things like that, right?" So I invite them to be the expert in another topic, and then they start to see me as a pupil, as a student, and then I get to hand some power over back to them. And then I think it's easy for me because I get to play, not play, but I do have a lot of language barriers. Sometimes people would say like a slang, American slang, or like they'll use like an analogy, and I don't get it. And
Mm,
I practice stopping and saying, "What does that mean? What's that?" And I think it's great because a lot of times like fake it until we make it, right? We don't ask questions. So I ask a question, and then they in turn they teach me something, and they're like, "Oh, I just taught this doctor a new English word," you know, which I think is great to do. And then I laugh a lot, and then I also interact with my medical assistants a lot. Especially my medical assistants are usually, I work primarily with Spanish speaking patients, and they're the certified interpreter, but they're also my medical assistants. So a lot of times they soften what I say, or they interpret in a culturally appropriate way, and then I would interact with them, and I would put them as more of to have more power. Like I'm learning a new Spanish word from them, or like, oh, is this what you say? What did I say? Oh, don't say that, or something, some kind of behavior that makes it kind of funny. And the patient observes and they're like, oh, they're treating their team this
mm.
respect. And then who, like by diffusion, also share my language and my culture. And that means this person respect my culture and my language too. So I think that's another way to do it. And I also like try to invite my medical assistant sit down so that no one is like standing, like they're in timeout or something in the office. A lot of times
Time
people
out.
refuse to. Yeah, you know, isn't that so crazy? Like the students, like you can always tell who's the lower on the power dynamic, like the hierarchy in the room, right? Like the attending is sitting, and the resident is like typing, and the fellow is typing. The resident doesn't even get to have a computer, and then the medical student is like writing on a paper, and everybody is standing. It's like kind of crazy. It's kind of crazy what
There's
we
we have
do.
medical culture is so weird.
It's so weird.
Um, Said, I'm so grateful that you joined me today. It's always such a pleasure to chat with you, and so I'm so in love with this book. For all of you, thank you so much for all of you who came today. I really hope you pick up a copy of Consented. I'll pop out a link where you all can get it when I post the recording later. Um,
I know Lisa has blurbed that book too, so
I was very fortunate. I felt very blessed to get to read it ahead of its publication, and I was delighted
thank
to
you for
blurb
doing
it.
that. Thank you for supporting this work and being this work, to be honest. And you are where are you're my people. And
You're
then
my
if you know,
people.
and if patients are looking for ways to um, see medicine as a healing profession, the way that medicine was designed to do. If patients are looking for ways to humanize doctors and to see ourselves as fellow humans, for like uh, foremost, they need people who are their people, and you are their people, and I am their people. I'm your people. You're my people. We're here. Join the conversation.
Awesome. Well, for any of you who don't already follow Zed, make sure you follow her on Substack. Make sure you pick up her book, and we'll look forward to chatting again in the future. Thanks, everybody.
Likewise.